happens when we actually swallow. So swallowing is a highly regulated, complex process. So it's activated by peripheral receptors. And what that means is the information is coming in from the outside. So literally, the minute something hits your lip, the brain is lighting up in preparation for what might be coming. So be that a liquid or a solid, and it'll adjust with regards to viscosity, volume, temperature, taste, texture, all of these things. So the brain takes in that information and responds to that input by then sending the exact right signals to execute a series of coordinated, sequential, and simultaneous movements. And that allows for the safe passage of liquid, solid, or even saliva to move safely from the mouth to the throat, into the esophagus, while keeping the airway closed, and all of that happens in about 1 second of time. So if we look here, this is an actual, what we call a video swallow. So this is what we do in radiology, and hopefully you can appreciate the speed and the efficiency of a normal swallow. So literally all of those things happen in just a very short period of time. And when we're talking about swallowing, that complicated dynamic process involves 36 muscles and 6 cranial nerves. And we separate swallowing into 3 stages: the oral stage, the pharyngeal stage, and the esophageal stage. Now, in the oral stage, you have to be able to have both the sensory and motor capacity to be able to control the bolus so it doesn't fall out the front of your mouth, for example, or fall out off the back of the tongue and cause you to choke before you started to swallow. You also have to be able to prepare the food or liquid properly to get ready to transit it. And then once that transit begins, that's when the swallow reflex is triggered and the pharyngeal stage motions begin to kick in. So during that stage, what happens is the velopharyngeal port closes off. That keeps food or liquid from coming out through your nose. The tongue base retracts. The larynx, which is your voice box, lifts up, moves forward. And inside the larynx, you have your vocal folds close. You have a pair of false vocal folds that close and a pair of area epiglottic folds that close. So 3 levels of intrinsic airway closure. Then the last is the epiglottis that just flips down and closes it off altogether. And all of that also happens as it gets up and moves out of the way so that the bolus can pass by it. And when it gets up and moves out of the way, that's what actually pulls the cricopharyngeal open. So all of that happens in that 1 second of time. Once it passes through the upper esophageal sphincter, also known as the cricopharyngis, it closes right back up and the airway returns, so the larynx returns to its resting position and you take a breath. And then the esophageal stage begins with all of the peristalsis that begins to happen. So, and given the intricacy of that function, it's easy to see, my computer is freezing up. Okay, I apologize. It might be my internet connection. And again,
I think you just, take your time, Teresa.
Okay. I might need to just double check. I'm going to go, okay. I've run this so many times. I apologize. It's one of those days. Hang on. I'm going to just get out of the screen share for a minute, and just check my internet connection. Oh, I see what the problem is. It's actually my computer is not getting power, even though it's plugged in. I apologize. This is not starting off to be.
No, it's all good. Don't worry. No. Not to worry about anything.
This is what's happening is there it goes. Okay, for some reason my computer is not receiving its power, and I am going to double check and get to another.
Oh, I think we've lost you, Teresa. I think we've just lost. Okay, back on.
Okay, good. All right. So given the intricacy of all of the action actions that need to take place, it's easy to see how any problem in any one of those sequence of events can cause a problem. So dysphagia is defined as any impairment in the ability to chew or swallow secretions or food. It is the leading cause of aspiration pneumonia and can be caused by a variety of neuromuscular, metabolic, infectious diseases, CVA, which is also known as stroke, TBI, traumatic brain injury, head and neck surgery, radiation to the head and neck. It is a devastating loss of function, and it exists within all age groups. So you can be born with difficulties sucking and swallowing, or it can happen at any point in your life, either through progressive disease or a sudden or acute onset. And so what actually is happening, the physiological causes of dysphagia can be an impairment in the neural drive to the swallowing musculature. You can also have insufficient sensory feedback for efficient motor control. You can have myofascial restrictions. You can have a disruption of airflow gradients. You can have anatomical changes to the swallowing musculature, and you can have muscle atrophy. So dysphagia is not a disease, but rather a disorder. And unfortunately, is many times the manifestation of an underlying disease or serious problem. So who gets it? Well, the biggest population is stroke. It's the single most common cause of dysphagia. It occurs in at least 1/3 of all stroke patients. 67% of patients experiencing a brainstem stroke will have dysphagia. 43 to 54% of all stroke patients will experience aspiration. 37% of them will develop pneumonia. 48% will develop malnutrition. And the overall mortality rate is 45 to 68%. And that's mostly due to complications related to dysphagia. So this is a nice pie graph to kind of give you a visual representation of the breakdown of dysphagia among patient populations. And so you can see stroke comprises the primary focus of this, but dementia is another fairly big population, as well as Parkinson's disease. And there's your TBI, head and neck cancer. So that's post-radiation head and neck cancer treatment, and then 5% of other. So what happens when you get dysphagia? What are the risks? What are the consequences? Well, aspiration, which is defined as food or liquid entering the airway and passing below the vocal folds. So how many of us have had that very uncomfortable sensation of something going down the wrong pipe? Well, we may or may not have actually aspirated, because typically in a normal person with normal sensory mechanism, once it hits the vocal cords, that sets off that severe cough reflex. And that's the purpose of that cough reflex, is to expel whatever is there out of the airway and to be re-swallowed or coughed out of the mouth. And aspiration actually goes below the vocal folds, enters into the bronchial tubes, and ends up in the lungs. And that obviously can cause, at the very least, some respiratory distress. But if that food or liquid remains in the lungs, then a bacterial infection begins to develop, and that's what's called an aspiration pneumonia. And unfortunately, that can be fatal. In addition to that, you can just have choking. So whereas in aspiration, it's going to pass through the level of the vocal folds, and choking, it gets lodged in the airway. And unless someone Heimlichs you, or you're able to cough it out yourself, then that, of course, can lead to a certain death or an anoxia from lack of oxygen to the brain. And then you have a set of patients who literally cannot swallow their own saliva, their own secretions. And by the way, we produce about 1.5 liters of saliva a day for the Americans. That's a quart. You've all been to the dentist. You know how much saliva is activated just by opening up your mouth. So in a tracheostomy, so these patients that can't swallow their own secretions or saliva have to have a tracheotomy, which is the hole that is cut there in the tracheal opening, which forms a tracheostomy. And that becomes a source for suctioning. So they literally have to suction out their own secretions so they don't drown. It's a great way to start your day, right? Or your lunchtime. Hopefully you all ate. And then, of course, if you're having problems swallowing, you're going to have malnutrition, dehydration, and weight loss, because you're not going to be consuming as much. And you can also be aspirating, but just more small amounts, and that just kind of leads to like a chronic respiratory illness. And then in cases where it's absolutely unsafe for the patient to be eating by mouth and they become NPO or nil per oral, nothing by mouth, then they'll receive what's called a PEG tube or a J tube placement. You can also get a nasal gastric tube, but usually those are more short-term. PEG tubes and J tubes or more long-term. So the costs of dysphagia are huge, predominantly in human life. Aspiration pneumonia is the 5th leading cause of death in the United States and the 4th leading cause of death in the elderly. And aspiration pneumonia in the United States alone costs $3 billion a year. So in order to really quantify the risks and the costs and the healthcare burden associated with dysphagia, a group out of the Mount Sinai School of Medicine and Department of Otolaryngology did a report called The Consequence of Dysphagia in the Hospitalized Patient, Impact on Prognosis and Hospital Resources. And their objective was to determine if comorbid dysphagia in all hospitalized patients has the potential to prolong hospital stay and increase morbidity. So they looked at 77 million estimated hospital admissions, and of those, they found 271,983 were associated with dysphagia. And what they determined was the median number of hospitalization days for all patients, regardless of their admitting diagnosis. Remember, they weren't admitted with dysphagia, they just were discovered to have dysphagia while hospitalized. And so those patients were there on an average of 4.04 days compared to 2.4 days for those patients without dysphagia. So almost double the amount of hospital days. And mortality was substantially increased with patients with dysphagia, especially those associated with rehabilitation, intervertebral disc disorders, and heart diseases. So their conclusion is dysphagia has a significant impact on hospital length of stay and is a bad prognostic indicator. And early recognition of dysphagia and intervention in the hospitalized patient is advised, obviously, to reduce morbidity and length of hospital stay. Another study replicated these results entitled The Economic and Survival Burden of Dysphagia Among Inpatients in the United States. They looked at 88 million discharge records. And their final conclusion was dysphagia affects 3% of all adult US inpatients and is associated with significantly longer hospital length of stay, higher inpatient cost, a higher likelihood of discharge to post-acute care facility and inpatient mortality when compared to those similar patient hospital size and clinical characteristics without dysphagia. So again, the only thing that was different comparing apples to apples among these patients was those that had dysphagia were going to fare significantly worse, be there a lot longer, and have a lot longer health term costs and needs. So not only in the US has this been examined, but there in the UK, David Smithard at King's College Hospital was able to determine that the prevalence of dysphagia in the general population is 16 to 23%, increasing to 27% in those over 76 years of age. This is a huge group of people. And his statement was dysphagia is a common problem that accompanies aging. It has many etiologies, many of which overlap with other giants. Dysphagia is associated with poor outcome, including increased frailty, institutionalization, and mortality. And as for these reasons, it should be recognized as a true geriatric giant. So when we look at the overall prevalence in the general population, we're looking at 1 out of every 17 people, greater than 50% of all elderly institutionalized. We have 70% of all patients undergoing head and neck cancer treatment will have dysphagia. 80% of the people who experience some sort of neurological disease will have dysphagia. You have 33% of all rehab patients, 16 to 23% of the world's population. And this is one of the most disturbing figures. Only 22% are even referred for treatment. So again, we're missing a large group of people whose lives could literally be changed forever and even potentially be saved by just identifying, recognizing, and providing proper treatment. So let's talk for a minute about COVID. So would that in some way increase the prevalence of dysphagia? Well, yes, unfortunately it does. So we know now that approximately 3.2% of patients with COVID-19 require intubation and invasive ventilation at some point in the disease course. And we also know from other research that nearly 60% of patients who are intubated in intensive care units will experience dysphagia, and approximately 50% of them will aspirate. So we can safely say that with having COVID-19 now on the global picture, that this is only going to increase the prevalence of dysphagia. So I want you to think for a minute of the last meal you had and taking that nice slug of cold water. I want you to think for a minute about the best meal you've ever had. And you can probably still even render up some savory feelings of that wonderful meal. And now I want you to think of being told you can never eat or drink again. So no more pizza, no more beer, no more tea, no more fresh salmon, no more fresh vegetables or fresh fruit, no more fresh baked pastries, no more grass-fed beef, none of these things. This is what happens to people with dysphagia. They are either prevented from eating anything at all, or what they are given to eat vaguely resembles a food substance. It's a thickened liquid or a pureed diet. Or they end up getting fed via a feeding tube. So this is what a PEG tube looks like. So PEG stands for percutaneous endoscopic gastrostomy tube. And basically what happens with a feeding tube is you're bypassing the entire mouth, you're bypassing the throat, you're bypassing the esophagus, it's just straight to the stomach. So you're taking a formula, and unfortunately, in many cases, a chemically based formula that's not even food based, and that is what you are sustaining yourself on. So this has all been taken away for these patients with dysphagia. And the problem with the feeding tubes is they are not without their own unique set of complications. So how many routine procedures are done in medicine that have nearly a 70% rate of complication, with a 30-day mortality rate of just under 30%, or a 1-year mortality rate of over 50%. And the very reason why they're placed, which is to prevent an aspiration pneumonia, they're still likely going to get just under 40% chance that they will still get an aspiration pneumonia, the very thing that the PEG tube is placed to prevent. As a matter of fact, in an article in the New England Journal of Medicine, Dr. Merrick stated that feeding tubes offer no protection from colonized oral secretions, which are a serious threat to patients with dysphagia. And furthermore, scintigraphic studies have revealed evidence of aspiration of gastric contents in patients fed by gastrostomy tube. So over the long term, aspiration pneumonia is the most common cause of death in patients fed by gastrostomy tube. So the most common management strategy for these patients is failing them miserably. It also costs a lot of money. So again, just in the US alone, it's 6% of the annual budget, more than $670 million, just to place and to maintain a feeding tube. And so that equates to about $31,832 a year per person, which includes the initial placement, the formula that has to be put in that, and guess what? Hospitalization for major complications. And yet there's no evidence for reduction of pneumonia. So obviously, the better plan is to identify and fix the dysphagia so we can avoid all of this associated negative sequela and cost. So Conventional management strategies have little support. We know that if you're just managing the dysphagia, you're not fixing the problem. You're just helping the patient deal with it. And that in and of itself may actually lead to a worse outcome. So, are we missing the boat? I think so. So, what's the logical way to approach this? So when you look at the principles of rehabilitation, in order to restore, to fix the swallowing problem, you got to have a plan, right? And that plan needs to be biologically plausible. And that treatment needs to match an understanding of the mechanism of dysfunction. Dysphagia can happen in a variety of populations and manifest itself in a variety of ways. And you need to understand what is actually causing the dysphagia before you can know how to fix it. And you also need to understand what other medical or surgical interventions may also be necessary. So in my opinion, the purpose of dysphagia rehabilitation is to restore swallow function to the highest level possible in order to prevent further complications and also promote optimal quality of life. So in summary, we can say that dysphagia is a highly prevalent disorder impacting millions worldwide with serious and sometimes deadly consequences. And the cost to the healthcare system is staggering, and it's only going to increase over time. And so the rehabilitation of dysphagia must be designed to meet the unique causes of dysfunction with strong consideration for efficacy and cost. So enter in dysphagia rehabilitation with the Biber Protocol. So what is the Biber Protocol? Well, the Biber Protocol is an evidence-based technique leading to better outcomes and quicker patient recovery. And it utilizes a method of delivering painless and effective neuromuscular electrical stimulation, known as NMES, to re-educate the muscles necessary for swallowing, voicing, and facial movement. So the Biber Protocol uses a form of electrotherapy, and electrotherapy is defined as the use of electrical impulses applied externally to evoke a physiological response. So you're placing the electrical stimulus somewhere on the body with the anticipation that that body will now respond to that stimulus in some way, shape, or form. And how that electrical stimulation is manipulated and modified is going to directly determine the type of physiological response that body will have. So in the book entitled Electrotherapy, Evidence-Based Medicine by your Tim Watson, who will also be speaking at this seminar, Tim states that all electrotherapy modalities, with the exception of biofeedback, involve the introduction of some physical energy into a biologic system. And then that energy brings about one or more physiological changes, which are then used for therapeutic benefit. So clinically, it's probably more useful to work the model in reverse. Determine first the nature of the problem to be addressed, which is, again, what I was saying before. Then you establish the physiological changes that need to take place in order to achieve these effects. And then lastly, the modality which is most able to bring about the changes to the tissue or tissues should be a relatively straightforward decision. So what we're saying is, again, going back to that biologically plausible, understanding the mechanism of dysfunction, and would NMES indeed have a positive effect on this particular patient with this particular dysphagia? So what is NMES? So NMES is very discreetly defined as the use of electrical pulses that are modified and manipulated to excite peripheral nerves and evoke an action potential through a transcutaneous medium. So remember when I was giving you the original description of what happens when we swallow, remember it is peripherally driven to begin with. So here we are providing a peripheral stimulus, and then that evokes the action potential in the same way that the brain sends the signals down to start all of those movement patterns. The NMES can replicate that. So in simple terms, you have electrical pulses that tell the nerve to tell the muscle or muscles to move. Now, it's very important that we don't confuse this with TENS, that we don't interchange those terms as much as they seem very similar in their title. TENS, standing for transcutaneous electrical nerve stimulation, sounds very similar to NMES, does it not? But TENS has really been designed and defined as a use of non-invasive, low-risk nerve stimulation intended to reduce pain, both acute and chronic. So TENS is the term we use for an electrical stimulation protocol designed to actually inhibit nerve transmission. So in TENS, you're stopping the nerves from transmitting the noxious information to the brain, therefore the brain doesn't perceive pain. So it's an inhibitory protocol. That's the complete opposite of NMES, which is an excitatory protocol. You're sending those messages, you're trying to get the brain to respond and the muscles to move in a way that they should be moving. So it's exciting the nervous system, not inhibiting it. So this is why these two terms should never be interchanged. Two completely different forms of electrotherapy. So in NMES, you have this nerve action potential. And in order for that to happen, in other words, for a muscle to move in the body, it's going to happen one of two ways. Either it's going to come as a command from the motor cortex or from electrically induced stimulus at the periphery. Now, the mechanism of action potential propagation is fundamentally different in both the direction of propagation and the recruitment order of the motor unit. So basically, one comes from the top down, the other comes from the bottom up. But it's these differences that provide the basis of the advantages of NMES when the neuromuscular system is deficient and the ability to control muscle activation and relaxation is either cortically or subcortically impaired. So the major emphasis of action potential generation is based on the fact that a membrane can only be excited when an outward current is induced, and that's the basis of externally applying an electrical stimulus to, again, excite the underlying tissue. Send that message up to the brain to get things going. So the Biber Protocol is the master and the original. It was developed in 1999. And there I am, many moons ago, assessing the contraction on one of my patients. So it's based on standards well established in electrophysiology. The protocol was developed in '99 as a collaborative effort with speech therapy, physical therapy, and otolaryngology. The testing of the protocol occurred over a 2-year period of time, and the initial data revealed a 2.5 gain on a national outcome measurement system compared to the entire United States dysphagia outcomes. And these findings were presented at the Dysphagia Research Society in 2003. This was the very first NMES for dysphagia training course ever held in the United States. It's worldwide coverage. The Biber Protocol has been used nationally and internationally by therapists and patients alike since 2002, and there have been well over 1 million. And quite frankly, that's probably an extremely conservative figure, but I'd rather err on the side of caution. Well over 1 million treatments using the Biber Protocol with consistently reported excellent outcomes and without any adverse effects. So why would we use NMES for dysphagia? Well, we know the old saying, if you don't use it, you lose it. So that was first coined by Taub in 1980, who said that if not used, the affected body systems will undergo cellular, tissue, segmental, and systemic reorganization. And these metabolic and structural reorganizations are reflected in the adaptation of the central nervous system to the current status of non-use as the norm. So we all know the longer that you misuse a muscle or you don't use a muscle, the weaker and more deficient it becomes, and the more the brain adapts to that as being normal. Well, think about it. If you're not allowing a patient to eat or drink by mouth, what's happening to the system? You're not allowing any of that peripheral input. So again, no taste, no texture, no temperature, no anything, right? So you're not providing that input into the brain. And so these muscles are becoming more and more dysfunctional and harder to recover. The beauty of NMES is
you can keep these muscles active and moving without giving the patient anything to eat or drink. You can still have them undergoing the swallowing process. Another reason for using NMES is the concept of forced intervention. So forced intervention is defined as any physical intervention that forces the patient to actively perform the task better than he or she could perform without the intervention. So again, as these muscles are becoming weak and more atrophied and they're not able to swallow efficiently and safely, you can again activate those muscles peripherally with the electrical stimulus to a much greater degree. So you get a much stronger contraction than the patient could ever achieve on their own without that electrical stimulation. So here's a small example of how the Biber Protocol works. So there are 2 electrodes that are placed under the chin in the submental region, never on the neck. That electrical stimulation sends a message to the brain to move the muscles associated with swallowing, and you have the patient swallow at the same time. And that's a key component. We're not actually making the patient swallow. We're just moving the muscles associated with swallowing. And the key is to have the patient do a volitional swallow or a facilitated swallow at the same time. So what's the evidence? So since 2000, there have been 177 published articles just on electrical stimulation and dysphagia. So in a review of these articles, I was able to pull out 65 that met the criteria for surface electrical stimulation in the exterior region, so excluding, for example, animal studies or invasive electrical stimulation. And out of those 65 studies, there was 1 survey, 5 case studies, 4 retrospective studies, 42 prospective studies, and 13 meta-analyses and or literature reviews, which, as we know, is generally considered to be the highest level of evidence. And so globally looking at these studies, what did we find? What we found is 69% of those studies had a positive outcome to the use of NMES. 22% had an inconclusive or mixed result, and 9% had showed no effect. But Tim Watson would say that dose selection is critical. And he states that many research publications that have identified a lack of effect of intervention X, yet other researchers have shown it to work at a different dose. And that is really critical. And that is a common flaw among all electrical stimulation literature, not just NMES and dysphagia, but among all of it, where the wrong type of protocol is used, either in error due to ignorance or due to a planned failure event and an inherent negative bias. But overall, I think we can safely say that there is more than sufficient evidence to support the use of NMES for dysphagia. In another article where they did their own analyses of 180 studies, and they broadened their search to include NMES on facial paralysis and voice problems, which are the 2 other disorders I treat as well with the Biber Protocol. And their overall conclusion was evidence collected to date is encouraging, particularly for the treatment of certain forms of dysphagia and laryngeal paresis, which again would make sense. It's not going to work for every patient in every situation. And one final study to look at the science behind it, in Korea, they did a study, curious to see is what level of the brain lights up and retains that information over time with treatment. So they did just 10 treatments with patients, and all of the patients improved functionally, and that was able to be determined through that radiographic study that I showed you in the beginning. That's called a modified barium swallow, or an MBS. But what they also did in addition to that is they looked at brain mapping. And you don't need to have ever seen a transcranial magnetic stimulation map to know that this is substantially better than this. So this is the degree of brain activity that was occurring prior to treatment when a patient needed to swallow. And this is the degree of brain activity that exists in that patient's brain now following the treatment. So a 400% increase in cortical mapping after therapy. So remember, NMES for dysphagia is indeed evidence-based. So we can safely agree that all patients are not the same. So you can have patients who were born, again, young babies who are born with difficulty sucking and swallowing. You can acquire dysphagia at any point in time in your life, and it can be, again, both sudden onset or progressive over time. You have patients who are unable to take anything at all by mouth, and some who are able to eat, but it's a modified diet. You have it caused by treatment from head and neck cancer, neuromuscular disease, osteophyte stroke. So it's safe to say that one size will not fit all. And so that's where the Biber Protocol is different than a couple of the other protocols that exist out there that do use electrical stimulation to treat dysphagia. So the Biber Protocol teaches the science of electrotherapy, not a specific device. It's the only method that provides an understanding of the various parameters and how and when to modify and manipulate and achieve a custom patient-specific program. It's also the only program out there that supports home use, and it has lifetime support from me. So parameters matter. So the standards for electrophysiological effects have been well established and documented in the rehabilitation literature, textbooks, and resources. And proper use of NMES dictates that you stimulate the right muscle at the right time with the right parameters to achieve the desired outcome. So in an article entitled Neuromuscular Electrical Stimulation for Skeletal Muscle Function and published in the Yale Journal of Biology and Medicine, Doucette, Lamb, Griffin kind of encapsulated all of what I've been teaching all these years by saying the delivery of electrical stimulation can be customized to reduce fatigue and optimize force output by adjusting the associated stimulation parameters. A full understanding of the settings that govern the stimulation is vital for the safety of the patient and the success of the intervention. Consideration should be given to the frequency, pulse width, duration, duty cycle, intensity, amplitude, ramp time, pulse pattern, program duration, program frequency, and muscle group activated. So again, pretty much what I've been preaching from day one. So key points. NMES does not evoke a swallow. It evokes a movement pattern that's associated with swallowing. Another key point, the goal is to contract the swallowing muscles and have the patient swallow at the same time. This is true neuromuscular re-education. Key NMES principles dictate that the muscle stimulated must represent a normal movement pattern. So the normal movement pattern we're stimulating here is hyolaryngeal excursion. So if you will, when you swallow, and you can all just put your fingers on your throat and swallow. That is your larynx being lifted up and rocked forward. That is hyolaryngeal excursion. That's what closes off the airway and opens up the upper esophageal sphincter. That is exactly what we're able to replicate with NMES when we use the right parameters on the right muscles at the right time. In addition to replicating that movement pattern through NMES, NMES principles state that you must pair that movement pattern with an actual task. And so the actual task that we are performing during that singular movement is a single swallow. So naturally, we have a contraction and relaxation time that matches with the swallowing act. So the goals of treatment are to achieve a contraction of the suprahyoid muscles while keeping the patient's comfort paramount, and simultaneous swallowing with stimulation with the greatest degree of ease. So just a little pop quiz. Do you want to lift the larynx up or pull it down? Well, if we pull it down, we're returning it to its resting position, and that's when we take a breath, and that's not going to help the patient swallow any better. So obviously, we want to lift.
And we want to facilitate or inhibit normal movement. Well, clearly, we want to facilitate. So why NMES for dysphagia? Well, we know that NMES elicits brain plasticity, which enables recovery of swallow function. It stimulates the cranial nerves and muscles that are often missed with conventional swallowing treatment. And NMES facilitates cortical reorganization, including providing sensory stimulation, providing movement, kinesthetic feedback, promoting functional task-specific use patterns, and inducing repetitive swallows. So one key point is NMES should never be painful in any way, shape, or form. A skilled clinician has the knowledge of the fundamental principles and understanding of the various parameters, and adjustments therefore can be made in order to maintain patient comfort and still achieve muscle contraction. So quickly, with electrode placement, again, is in the submental region. Why the submental region? Well, we only have access, again, to the external body here. The only muscles associated with swallowing are going to be the suprahyoids and the infrahyoids. So when we stimulate the suprahyoids, their job is to lift the larynx up and pull it forward. So we know if we facilitate a movement pattern there, we can pair that with a swallow, and that's going to result in true neuromuscular reeducation because it is the suprahyoids that perform that task. Stimulation of the infrahyoids, which are down here, facilitates laryngeal depression or return of the larynx, which of course would not make sense in facilitating. And simultaneous stimulation, and these are some of the protocols that are out there, of both suprahyoids and infrahyoids at the same time, not only do not facilitate any movement because you are facilitating two opposing muscle groups at the same time, but you're literally locking the larynx in place. And that would defy the principles of NMES that dictate that the muscle stimulated must represent a normal movement pattern, and that movement pattern must be paired with an actual task. So here's a real example of a real patient. Actually, this isn't even a patient. This is a physical therapist in the Philippines. And so you will watch as this is the electrical stimulation coming on.
Okay,
and
good. All right. Good. Try not to laugh
laugh.
this time. Keep your lips closed.
So again, the stimulation's on a rest time now, and in a moment it'll be the cycle time will go on, and you'll see the larynx, hyolaryngeal excursion there. Right back down.
And
again,
we'll do one more.
Just like a swallow, it's a very good.
So here's a very visible contraction that I have right here.
We're going to watch it again one more time from a different angle. Again, suprahyoid placement, and you can see again a very beautiful, nice, natural contraction. So how does the Biber Protocol facilitate neuromuscular reeducation for swallowing? Well, it maintains and strengthens muscle mass during inactive periods, which is huge, during that nil per oral or NPO or nothing by mouth phase. You're able to maintain or gain range of motion for optimal hyolaryngeal excursion and airway closure. You're able to facilitate voluntary motor control for swallowing maneuvers. You're able to also increase sensory awareness, which is a huge component to swallowing safely. If you can't feel what's in your mouth, even though the muscles might be moving, you can still aspirate. And you're able to restore normal balance to a system as ascending sensory information is reintegrated into movement patterns, which feeds into the neuromuscular training principles of intensity, specificity, and transference. So looking at some of the exceptional positive outcomes, so there was a home healthcare company called Amedisys, which is the largest home healthcare company in the United States. They saved over $1 million a year by converting from VitalStim, which is a protocol some of you might have heard of, to the Biber Protocol. They had over 300,000 speech therapy visits per year with hundreds of speech language pathologists employed. They were able to increase their speech therapy services to greater than 10%. And what they found is that their outcomes, very similar to my outcomes in 1999, 19% higher clinical outcomes compared to any other company in the United States.
And the post hoc examination of the Biber Protocol revealed a significant difference in both cost and outcomes. So the Biber Protocol, again, is the original NMES, developed in 1909 and introduced to the public in 2002 prior to any other electrical stimulation protocol for dysphagia. There are no adverse effects, consistently positive outcomes, open access and support, over 1 million treatments performed by thousands of clinicians all over the world, significant scientific validation and support, and the only NMES that encourages and supports home use, which segues into our device that TensCare is manufacturing. So this is a portable NMES device called the Biber Plus. There are pre-programmed exclusive protocols that I have developed over 20 years of clinical experience, but in addition to that, you still have all of your custom programming available. There is a really beautiful feature of a built-in trigger switch, and what this allows you to do is to specifically time the stimulation with the act of swallowing, and that's huge. It's very suitable for home use. We provide comprehensive training and education, and there's excellent customer service and support. So I'm going to segue very briefly into COVID-19 and how that has radically changed the world, and this has a significant impact on now how therapy is delivered, and it's propelled telehealth to the next level with support from all agencies and government administrations. In telehealth, it empowers the patient, it promotes the health and well-being of people by preventing the spread of the virus, overcomes many barriers to access such as transportation, family work obligations and scheduling, respects patients' privacy, and reduces clinician workload. So telehealth and a home NMES device is the perfect marriage because it provides multiple opportunities to engage in therapy beyond what was ever achievable in person. You can safely do NMES 2-3 times a day, 5-6 days a week. So you could never go to therapy that often, but you would now have access to a wonderful treatment tool at your own disposal. Provides potential for the entire support network at home. It liberates the clinician to see more patients, supplies additional support for patients via a dedicated and knowledgeable distributor, and obviously is going to improve overall outcomes. So in summary, not all eSTIM protocols are created equal. Parameters matter. A skilled user of NMES must understand and know how and when to manipulate the parameters such as frequency, pulse duration, ramp, contraction, relaxation time. Specific training is necessary. Electrodes must be of good quality. NMES has substantial and strong evidence to support its use for the rehabilitation of dysphagia, and the Biber Protocol is based on established principles of electrotherapy. Home use of NMES is indicated now more than ever, but this is purely an adjunctive modality. It does not replace, but rather augments all other clinical interventions. So, in conclusion, wherever the art of medicine is loved is also a love of humanity, and James Beard, food is our common ground, a universal experience. So this is actually me, and this is not a photoshopped picture. This is about an hour and a half from my home in Costa Rica. And I encourage you all to go check out my website that has a wealth of information that you can find on their video library, the history and the development, frequently asked questions, more information than you probably ever wanted to know. You can find on the biberprotocol.com. So I'll end there and open it up for questions.
Thank you very much, Teresa. I know we put you on the spot, but you've done so brilliantly well. Thank you. I'm just going to bring everybody to the room so they can see and hear us. And if there are any questions, anyone is welcome to interrogate Teresa. The device is brand new to us. We've only produced a very limited batch of the products yet. It's predominantly targeting at the Asian market at the moment. That's due to Teresa's sort of collaboration with the Gary Ho that is actually based in Hong Kong. But we will we will be talking about this new Dysphagia Biber Plus device more with all our distributors in the due course. We have an agreement that we can promote it around the world. So if you're interested, or if you know that your supply chains of your partners that in your market will be interested, just obviously get in touch with us or Teresa to find more information on how exactly it can work. And then also just to sort of give credit to Teresa. Teresa is running professional workshops where she sort of actually educates, I suppose, from students to professionals, and then that session ends up with a certificate, right? I don't remember how many hours it is, Teresa, maybe
About 10 hours.
So it's an online session that she runs to sort of help those use the product.
Yeah, and actually I misspoke. So we, because now it was about a 10 to 12 hour course, depending when I taught it live. So what I've done in the context, again, of COVID-19 is I've developed what I call a hybrid course. So in the hybrid course, there were 3 pre-recorded learning modules online with a comprehensive test at the end, which the people must score 90% or more to proceed to the next level. The next level, and that's about 3 hours. Well, I say 45 minutes, but it gives them a few minutes. So approximately 3 hours. And then there's a 4-hour live Zoom course where they're there and I'm doing the live training. And then the last portion is the lab portion. And that's the part that we would work out with people there. Like right now in Asia, Gary's company is doing the lab portion. And the lab portion is where the clinicians are learning the electrode placement, trying it out, becoming familiar with the device. And so he's running those. I have a trainer there in Hong Kong that works with Gary, who does the lab portion. So what I'll be doing now in the future is identifying people, for example, in the US that can do that as well, people that have been trained by me, and also in Europe as well. Or I can also train some trainers. So that could be, again, one of the distributors that wants to take on that responsibility to be one of the lab portion trainers.
Mm-hmm.
And that's usually, it depends. If it's one-on-one, you can do it in about an hour. If you want to do a small group, you might want to allow a couple of hours. And then a larger group, obviously, the more people, the more time you need to allow to kind of get around and make sure everyone's doing it properly.
Good. I suppose out of us all, Hannah was the most probably relevant person, so to say, to listen to that session. I don't know, Hannah, if you have any questions, because you said you've never heard of this.
No, I was pointing out, we because I work in a special school for speech and language, we don't have any students with dysphagia. I'm not dysphagia trained. Mm-hmm. So for me it was more of interest if there's any scope for the technology for using on speech musculature at all.
Well, there is.
Yeah. Yeah. Oh, because we currently we use biofeedback at the moment. We use electropalatography and ultrasound for working on speech, but this is another obviously really amazing potential use as well. So yeah,
it's so with speech, although it's not something I generally teach, I probably, maybe you and I could develop something together. But typically what I teach, because I'm teaching the science of electrotherapy, once you understand how it works, why it works, and what would be biologically possible, then you are really free to look at. So I used to, for example, cut electrodes kind of to go around the lips to work on lip closure. And there's lots of facial placements that you can do more for facial paralysis. But certainly, if you're using electrotherapy properly, if your idea is to evoke a muscle contraction and have them perform a task, so in that case, it would be dense speech sounds. Now, you're going to be limited to mostly labial speech, but you can also work on voicing as well. But that doesn't mean that there aren't some other potential uses that you could apply electrotherapy for speech sounds. I know certainly many therapists have done so.
Okay, great. Yeah, thank you.
Any more questions?
I have one question. Is basically related. If you're based in Costa Rica, how is your experience talking about the Biber Protocol on that area? Because I'm sure it's quite different probably with Asia or Europe.
Well, actually, believe it or not, I'm not really doing much in Costa Rica professionally. I'm just kind of living there.
I see.
Yeah. So because I don't speak, I'm not fluent in, I'm just learning Spanish. So my goal would be, you know, eventually, and I could always get a translator. Many of them speak English as well. But you know, I would need a distributor there. I don't have the support system there. I literally am kind of a one-woman show. And for years, I didn't necessarily promote any one device over the other. That was kind of the whole point. But it became more and more evident that having a dedicated device kind of that is based on these principles, that's, people really want that. You know, they kind of need to feel comfortable, like, oh, well, I'm going to, you know, okay, well, that's a device that she, you know, kind of designed. So therefore that kind of makes sense. So there's none of the support network there to be able to, for example, you know, have devices that they aren't approved in Costa Rica. So that would, so I have taught several people from South America through my courses in the US. So there are people in Central and South America that are using my protocol. But that was because they were able to, you know, again, attend the course in the US.
I think maybe you and me will be in contact just to see what's our
excellent.
options over there.
Okay, great. I'm definitely open.
Teresa, I just wanted to ask you a question that I can, since you've sort of said that these, the beauty of the device is that such that it can be used in the home environment, it does still need some sort of recommendation from either physiotherapist or speech therapist or...
Yes. So basically, the proper protocol is that a patient comes to see a clinician because they have a swallowing problem. So they're already being referred to the doctor for treatment, right? That clinician then is able to determine this patient is cognitively intact, they're a great candidate for home unit, or for example, it's a burden for them to come to therapy. You know, because of transportation issues or whatever. So they've identified this patient is a good candidate for NMES in general. And secondly, they're a good candidate for a home program. The clinician then trains the patient, defines the protocol. So they customize the protocol for the patient. They bring them back, you know, maybe a couple of times just to make sure that they're comfortable and confident with performing the treatments on their own. And then they send them home with the device, and that the device then is rented, or the patient purchases the device to take home. Then the clinician follows up via telehealth or by phone just to make sure the patient has any questions. We're actually working through this program in Hong Kong to also collect data because we think this could be very powerful for future use. To be able to determine the success of a home use program. So we're just starting that in Hong Kong. We've been sending patients home with devices, but we haven't really thought about looking at it from a data collection standpoint to see how successful it really is, how much how compliant the patients are, and what the outcomes are compared to, say, standard outcomes from a patient coming in to see a therapist on a regular basis.
And do you have any kind of evidence or sort of say how long that will be, or is that going to be like an ongoing use of the device, or is there sort of you use it for like, I don't know, 3 months to half a year to a year?
Basically, well, what Gary has set up is just that 3 months seems to be a standard. Quite frankly, many patients, I believe, within a month won't need the device anymore. And so they'd always be welcome, but typically they would be following up to be discharged from the device by their clinician. And that could also be done by phone. So let's just again say you have a patient who's extremely cognitively intact, but has a severe swallowing problem and has a good ability to be able to self-report. If they say, look, I'm eating and drinking everything, I'm not coughing or choking, this was the best thing ever. Well, they don't need to keep using the device if their dysphagia was caused by some sort of an acute event. Now, if they've got Parkinson's disease or some other progressive neuromuscular disease, multiple sclerosis, Lou Gehrig's, any of those, then they would benefit from long-term use of NMES. In all fairness, with those progressive neuromuscular diseases, they will reach a point where it no longer has an effect. But at that point, they're in the end stage of the disease and pretty much everything is breaking down. But we have seen with, especially with the Parkinson's population, they're able to maintain good eating and drinking, even in spite of loss of other motor skills. So again, and head and neck cancer patients who have received radiation therapy, there's a very funny cause of their dysphagia. It's chronic proliferative fibrosis. And so they often need a concurrent manual therapy program as well, but they also benefit from, again, just long-term use. So, it's once a day or once every other day, or maybe a couple of times a week, kind of depending on the severity of their case. So there are patient populations that benefit from long-term use.
Okay, good. I think you should bring up that image with all the different types of food that you've showed. It's very mouth-watering.
It's lunchtime. Yeah.
Yes. Well, and I missed my breakfast. So.
Yeah.
Oh no.
But it's okay.
Any more questions?
Not for that.
Or if you have a question but not sure whether to ask it or not, you can always send it later. I'm sure we'll have access to Teresa after the presentation, and there'll be another one on Wednesday. Again, if you think, Dorit, Adam, if you think that you have somebody that you would want to attend this, obviously there's another chance to come live and sort of see Teresa presenting. I just wanted to say thank you very much. Thank you for jumping on so early as well.
Please forgive me. I can be a bit of a space cadet. You might as well know that now. But it's not usually. I'm very good about, time is like very important to me, because that is one of the commodities you can't ever get back, right? So I'm very respectful of everyone else's time, and please accept my, again, apologies for being the blonde.
Don't worry about that at all. I don't think anyone remembers that at all. So thank you.
You're welcome. And I'll see you on Wednesday, and I'll get the time right.
Sure. Thank you very much. Thanks, everyone.
Bye,
yeah, there is another session at 2 o'clock. I know it's lunchtime.
I'm sorry, say that again? Are you talking
no,
to me?
It's just that, no, it's a different. I mean, you're always welcome to attend to it. It's our new product development session. Hanwei will be presenting.
Okay. Bye. I'll leave.
Thank you, Teresa.
Thank you. Thanks, everyone.
Thanks, Teresa. See you at 2, guys.
Bye, everybody.
Mhm.